Bonnie. Hi, Jeff. Thank you for
Good
providing the
morning.
music.
What's that?
Thank you for providing the music.
Yeah, that's all right.
Sorry I was late.
I just I can share the sound, but they've updated the thing, and I can't work out how to stop the sharing. I've just turned it off.
Oh, that's all right, isn't it?
Pardon?
That's all right. You don't have to stop sharing.
Yeah.
I'd love a bit of background, like thinking music every now and again. Can we get you to start it and stop it again? Hmm. I'm actually really excited about today's tutorial. So this is the first time that POCUS or like point of care ultrasound has been included in, or any of the AFAST or anything has been included in Edinger in this edition. And it's so applicable to both like internal medicine and emergency medicine. And I really, obviously, I do a lot of ultrasounds um, as part of my job. And I'm always amazed that, like, I'm internal medicine. I don't think of myself as a sonographer, but the amount of information you get when you know what you're looking for is like, it's well, not when you know what you're looking for, but when you know what you should be looking for and you're going in with a clinical question that's already formed, kind of thing. So the reason I raise that is because the point of care ultrasound model and the way that they teach it is because essentially going in with a like usually a question that has a binary answer, like yes or no, right? So like, is there free fluid in this abdomen? Yes or no? Is there a pneumothorax? Yes or no? And you're sort of going in like based on the clinical presentation, based on the blood work that you've got, based on the owner's history, you're going in with like very specific questions that you need to answer, which means that you're not ruling out a whole heap of stuff. There's other stuff that you're definitely going to miss, but you're going to be able to answer your questions with the sort of this point of care ultrasound, as long as you're asking reasonable questions. That's the important part. So I got so excited when I was making notes for this that I'd like, because I always make notes actually just in my like um diary, like in the like calendar diary, so that then for the tutorial, so that then I know if where those notes are the next time I come around to it because they're on the date. And then I got so excited that I went into so much detail that I ended up going over like weeks and weeks and weeks. So apologies if this goes on a little bit longer than planned. It won't. We'll finish at 9, but yeah, there's a lot of detail to go through. First thing Who does any ultrasounds?
Yes, I have.
You have? Yeah. In what setting, Jeff? Do you do a full abdominal ultrasound or are you like quite happy to use it in an emergency setting?
Look, no, it's been mostly full abdominal ultrasound in a medical situation. I've done very little as emergency.
Hmm. Anybody else?
Yeah, I
Uh,
used to do
Yeah.
emergency and first opinion scans, but don't really do so many anymore.
Yeah. Sarah?
just mostly AFAS and TFAS for emergency patients. I'm trying to get good enough to be able to do a diagnostic abdominal ultrasound, but it's a while off yet.
Yeah. Where do you work again? I should know this.
Sash.
Sash, that's right.
Yeah, those got to do 1,000 before you're good at it.
Yeah, exactly. I think I got a long way to go.
Yeah,
Yes.
keep going till you get there.
Um, yeah, I think that's a really good point actually. Like you are going to feel uncomfortable and like you're not answering the questions that you want to answer the first probably 50 that you do. But if you don't get through that 50, you never get to number 51 where you're like, yes, it worked. So just push through.
Keep going.
You can't do any harm with ultrasound, right? Like it's a completely harmless tool.
Yeah, I think for me, like I used to when I worked in regional practice, I used to do a lot, and I guess I just got too used to having very good ultrasound reports from internists that kind of clearly were like way more definitive. Like even my colleague in general practice did like I think she's very good at ultrasound, but she was always, which I think is fair enough, wasn't definitive enough. And then I just got used to having like really awesome ultrasound reports and then got kind of disempowered to continue my journey in ultrasound.
Yeah, that's been my problem too. I've always worked with someone that's better and I
Yeah.
wanting to give the patient the best.
Yeah. So I have very strong beliefs on this. I think the veterinary industry, I think we tend to do that. Can you imagine if the medical field referred everything to the best in the field all the time? Like who then takes over? And then the other thing about that, like if we're not, so my belief is the second best person in the room should be doing whatever you're doing in medicine, vet, legal, whatever, so that then you've got somebody in the room who you can defer to if you run into trouble. But you shouldn't have that best person in the room doing them all the time for like so many reasons. So I've done so many ultrasounds. I'm complacent. I'm really confident and I miss stuff. And when I don't have an assistant there with a checklist, making sure that I've checked everything, or when I don't have, like I've often got sonographers doing the scan and I do the report while they scan and they check stuff in a lot more detail because they're nervous about missing stuff than I would. Like I think they actually do it better than I do. And sometimes in the process of watching them do the scans, I'm like, yeah, I probably would have missed that. So if you're in a situation, clinical situation where you're like, oh, that person's the best person at ultrasound, it's going to be the fastest, it's the most sort of streamlined thing, I'm going to get them to do the ultrasound. Don't do that until you've had a go. It's a really nice opportunity to have someone better than you in the room and be able to do a completely harmless test. And then if you need help, you tap them in. And if you don't need help, it's really rewarding to have gotten away with it. So definitely have a go. What's the scariest thing about the ultrasound machine?
Getting the confounded thing to work. I'm trying to,
All the buttons.
I'm playing with it
Mm.
one at the moment. And, I can't get it to work properly. I can't get it to come off the cursor to come off one of the side um, sets of numbers, and
The
that
focus.
I can do measurements or things like that.
Oh, that's annoying. That
I
should
don't
be
know whether
pretty.
it's the machine or whether it's me. And
Yeah.
got the instruction book out, and that's even more confusing.
It's so much detail. Did you learn all the ultrasound physics in your instruction book?
No, I didn't didn't
No
bother. I
detail.
was just trying to
Yeah.
find out which buttons to press on that.
Um, to try and simplify things, I think there's three things that you should like learn how to use on your ultrasound machine to do most of your ultrasounds. And the rest you kind of go, oh, I really want to do this, and then you can look them up one at a time. But can anyone think of what the 3 buttons are that you need to be able to operate?
Probably pause, measure,
Oh yeah,
and record.
yep, good. What about in your settings?
Zoom in and out.
Yes, yep, good.
The frequency as well.
Frequency, good, yeah. So tell me, what are you going to do with your frequency? So say you're looking for this is like quite advanced, and this is not really a POCUS ultrasound, but a diaphragmatic hernia, like something really deep is what I'm saying. What frequency are you going to go up or down?
Down.
Down, yeah, exactly. So the deeper, the lower. So if you, and this is just a silly way of remembering how like that we're dealing with sound waves, because you kind of, it's so removed you can't hear it and you sort of forget. But if you've got a whale underwater, we know that the low sounds travel very far, and we're sending sound waves of low frequency, which is like a low sound, through water or tissue containing variable amounts of water. So low sounds are going to go further, high sounds aren't going to go as far. So that's excellent with frequency. So if you're looking for swelling over a joint, what sort of frequency are you going to be looking at?
High.
Yeah, very high. Yeah, as high as you can get on your machine. Basically, anything that's under 2 centimeters in depth, you want to be as high as you can.
So is it normally like 7.5? Is that
Yeah. Yeah, most of the probes kind of start at 7.5, and often they've got a range of like 5 to 13. 13 is pretty nice, but 5 to 11-ish. 13 is maybe a bit of a luxury. You'd be lucky. So frequency, depth. There's only the depth button. It's like literally up and down, like, or a knob. Like you can't mess it up. Like you go the wrong way every time by default, and you just go back the other way. So just have a fiddle. What's the third one?
The ball, the arrow.
Oh,
Oh yeah. Yeah, that helps. Yeah.
Well, POCUS is something that I think can make a difference.
It can make a difference. I feel like, oh, sorry, go Sarah.
Do you mean like the color Doppler flow? Is
Ooh,
that a
that's
good
probably more
button?
advanced. More
Oh,
advanced
that's a
than I'm
bit
thinking.
faster.
Yeah. What about the degree of blackness and whiteness?
Contrast.
Contrast, yeah. What's the name of that on an ultrasound?
Oh, geez.
resolution?
That's the G.
Gain.
Yes, excellent. Good. Yeah. So most of the modern ultrasound machines like acknowledge that none of us really know ultrasound physics. And there's a really nice button that looks like a settings button, and you push it and it fixes your image for you. It sort of detects like how dense the stuff that you're looking at is and fixes your gain for you. But you know those there's like a series of knobs on like runners, like a big stack of them. Yes, yeah, exactly. So a lot of the time the knobs are kind of just straight down the middle, like sitting between the flags on the runners kind of thing. If you're looking at really deep stuff and you're just losing your far field of the image, you turn your knobs onto an angle. So you increase your gain, which increases the whiteness in the distal field, so the brightness. So obviously when sound waves move through tissue, more and more and more of them get absorbed, which means less and less and less of them bounce back. And you can't detect the stuff in your far field. Whereas if you increase your gain, those like few that bounce back, you've turned up the volume on those ones. Does that make sense? So they then look as bright as the near field ones, even though less of them have bounced back. So gain, depth, and frequency are the 3. I wouldn't worry, like focus is really nice, but usually it's kind of in the middle and you can kind of adjust how hard you're pushing or your depth to get a reasonable image. And if there's 3 things I want you to be able to like play with without worrying you're going to mess up your image, they're the 3. And then if you're feeling confident, go for a focus and stuff like that.
With setting up the machine, I remember when we're at uni, like that you can use the the gain and do the settings when you start and see like the color gradient on the side of the
Mm-hmm.
go from like dark to white, or that you have to, I
Mm-hmm.
can't remember the actual way to optimize that. Do you do like, is that with modern machines like that, does that happen automatically, or should we be like most machines doing that before we start like setting all of that up so it's kind of calibrated so it's going to at the start, or just fiddle with it as needed?
I would fiddle as needed. The trouble is that you're looking at like the gain that you need when you're looking at a bladder is quite different from the gain you need when you're looking at a like aorta or like really deep structure. So I tend to adjust it as I go. Most of the time with abdos, I do set my gain. I usually have the knobs on that angle. And then if I'm like, this is just too bright or it's just too dark, I push the magic button rather than.
From top, so because you're on a screen, so is that from top left down to bottom right?
I actually
Like,
go top in the middle at the top down
yeah,
to bottom right. Yeah. So I'm
middle,
doing, yeah.
yeah, yeah, okay, gotcha. Yeah.
But that's
Machine,
my default,
machine at Chatswood doesn't have knobs like that. It's
doesn't
all
it?
buttons there and choose this mode and that mode and all that sort of carry on.
No, they're
I
just
was born to them. That's the trouble.
yeah, I feel like they need to release a POCUS machine that's only got these knobs on it, just so it's not so overwhelming. I'm sure they've done it because they've got those little Bluetooth ones, don't they? Ultrasound technology is like very exciting at the moment. It's going to be like 4 or 5 years before we've got amazing quality handheld broadcast to your iPad.
Mm.
All right, what about how you're holding your probe? How do you make sure that you're not missing stuff? So say we're gonna, oh, I'm gonna share my screen. I made a little slideshow.
Well, one of the things I do is always make sure I've got my finger on the either the raised thing or the where the light is, so that I know which direction it's pointing at.
Yes, perfect. Yeah. So you want where do you want your light pointing?
I usually have it on the top. To the left.
So cranial?
Oh, yes,
Yeah.
yes.
So if I go forward through this, so we've got dog's head on the left of the screen, and you can't see the light or the notch on this probe, but it will be pointing towards the dog's head. So it's good to have that really kind of standardized in your head because like I see when I'm training people to ultrasound, they'll do a full 360 without realizing, or like 180, and then you get like you're moving backwards and the probe's moving forwards and it kind of blows your mind a little bit. So if you're always holding it the same way, you get really familiar with when I move backwards, this is how it changes my image. When I move forwards, this is how it changes my image. So you always want to have your light either pointing towards the dog's head or towards the dog's spine. So you're kind of moving through that 90 degrees. So if I was to say, I didn't do any diagrams of this. If I was to say, fan the probe, so you're doing an ultrasound, I'm talking you through it. If I was to say fan the probe, what do I mean? I don't have one.
Have it in the same place, but tilting.
Yes. Yeah, exactly. Yeah. So I've got my probe facing towards the light facing towards the dog's head, and I'm going to tilt it side to side. So I'm going to tilt it towards the dog's right and left is fanning. So I said you've got your ultrasound image like this, and that's going to be moving through the dog that way, as opposed to rocking, where it's going to be moving that way. Make sense? So along the long axis of the probe. So fanning is along the short axis, rocking long axis. So if I put a probe on in one spot, so say we're looking at like the standardized kind of POCUS spots that you want to do in an abdominal POCUS. If we're going to spot number 1, which is the subxiphoid, xiphoid or xiphoid?
Xiphoid, I'd call it.
I would too. Anyway, probably doesn't matter. Subxiphoid location. We're going to have our light pointing towards the head and we're going to rock and we're not. We're going to fan and we're going to rock. And that means we're going to cover like a much bigger area than if we just put the probe on and get one little wedge through the abdomen, right? What about if we're sweeping? What does that mean?
You'd be moving the probe.
Moving the probe up,
Good.
down.
It's not just staying in one location. So you're actually moving the probe. So your picture is moving through the animal like that. And if you're sliding, you're moving through this way. Does this make sense to everybody? I need a video.
My brain does it, like, has always struggled with like how
Comprehension.
sound moves relative to the
Yeah.
the directions.
It's
But
weird.
it takes time. Like,
Yeah, totally.
normally if I just think it's like if it's the way that I'm thinking, I know it's the opposite way.
Yeah, right. So when I say rotation, this is what I mean, right? Yeah, good. So given that we want to either keep our probe facing towards the dog's head or facing towards the dog's spine, that's the 90 degrees you want to be working in. So you can get a full orthogonal view through that plane. You don't need to ever go that way because you've just got the other view that you just had, but in reverse. And you definitely don't need to go all around here because you'll hurt your elbow. So those views are pretty much all you need to do rotation wise. So long axis, pointing towards the dog head, short axis, pointing towards the dog's spine. Obviously, if you're looking at something that's not oriented craniocaudally, you're not getting long and short axes, but you know what I mean. Okay, so let's talk about what we're going to see when we look at this location 1 here. What are we assessing?
You can
The
see the
liver.
sorry.
Liver, gallbladder, and free fluid in that area.
Great. Excellent. So that's how you can position the dog any way you want. Often they're standing, often they're in lateral, often they're lying on their back if they're stable, but sometimes they're not stable enough. But liver, gallbladder, and what did you say was the third one?
Fluid, free fluid.
Fluid, exactly. So where does free fluid like to accumulate in the structures around here?
Probably in the gutter again, against the spine. I'm not sure.
So
between the liver lobes.
I think so. Yeah, exactly. So the areas where I think fluid accumulates the most is where you've got two rounded structures meeting. So you've kind of got the round edge of the liver lobe and the round edge of another liver lobe or the round edge of a gallbladder. And then there's just this little potential space that normally is kind of like sucked closed, but the fluid tends to accumulate in little triangles in these spots. So between the liver lobes is a really nice spot to see it. Whereas then when you get into the guts, it's very confusing because there's a lot of black and white structures and stuff like that. So free fluid, good one. Gallbladder, liver. What about the diaphragm? Do we want to look at the diaphragm for anything?
Ruptures, I suppose.
I think that's hard. Yes, in theory, but I've ultrasounded animals where I know they've had a diaphragmatic hernia, and I can see that the liver's definitely in the chest, but I can't definitively see a rupture in the diaphragm. Like there's definitely one, but like actually seeing it's really tricky.
Will you incidentally potentially capture like a really obvious pancreatic steatitis in that
Yeah.
xiphoid site?
Potentially. And there's another view. If we go back here, which other one would you?
5.
Number 3.
5 and 3. Yeah. So this whole area tends to be affected. That right cranial quadrant tends to be affected when you've got a really raunchy pancreatitis associated with peritonitis. Oops, daisies. So if you're
saying that seeing a diaphragmatic hernia, you'd be pretty lucky on well, not lucky, but it's
Yeah.
not easy to miss.
it'd have to be pretty obvious for me with a fair bit of experience. So I wouldn't like sort of say I can rule this out because I didn't see one if I was doing POCUS ultrasound. What about you're looking like cranially, like you're looking straight up through here. What else are you seeing in your far field?
Fluid in the chest or pericardial?
Nice. Yeah, it's actually a really nice bonus check that you get to do. And if you're seeing fluid in the abdomen, you want to check the pericardium. It's just a nice thing to just rule it out. So if we have a quick look at some like normals, this is that view looking longitudinally at the liver. And this is what the diaphragm looks like. It's a really nice bright white line. So has anybody ever seen a mirror artifact where the gallbladder looks like there's two gallbladders?
Yes.
Yeah. If you're seeing that, it means there's air on the other side of the diaphragm. So it means you've got like air-filled lungs or a massive pneumothorax, but air-filled lungs. So if you don't have any mirror and you're seeing black on the other side of your diaphragm, I would then say, okay, well, let's do an investigation for pericardial effusion or pleural effusion. So this is normal liver. It's just all grey. It's really boring. But what we can see in here is the difference between portal vessels and hepatic vessels. Hepatic vessels are just black. You can rarely see their walls, whereas portal vessels look quite bright. The main indication where I like to look at these two vessels side by side is, could this be right-sided congestive failure? In which case, what's the difference in those vessels going to be?
The
Dilation of the portal vein, size-wise?
Ultimately, but what's going to get dilated first?
the blood vessel,
Which one? Portal or hepatic vein?
hepatic.
Good. Yeah, so hepatic veins dump into the portal vena cava, which is the first vessel to get congested when the right side of the heart is failing. So you'll see side-by-side vessels and you'll say, oh, that's weird. That black one looks much brighter than, much bigger than that white one. And you can sort of say, okay, well, maybe the fluid in the abdomen is cardiac in origin. What's the other nice thing about having this kind of bright walled structure in a very kind of all grey structure?
You can determine if the liver is hyperechoic. You can look at it versus echogenicity of the portal vein.
Yes, exactly. Yeah. So sometimes, because echogenicity of the liver is so subjective and it has to be pretty abnormal before we can say that's not right. But if you've got a very hyperechoic liver, you all of a sudden don't get that contrast of those portal surrounds. You sort of go, oh, they all look like hepatic veins. Maybe the liver's a bit bright. What other ways can you check how bright the liver is?
Compare it to the spleen.
Right. Excellent. So when you're looking on your left window, you'll see the spleen and potentially the liver next door to each other. If they're sitting next door to each other, great. You can do a comparison. Otherwise, you've got to hit more buttons and that's probably going to get a bit much. All right.
So just to clarify, the spleen should always be like, if the liver is the normal echogenicity, it'll be lighter than the denser spleen.
Other way around.
The
Spleen's
spleen's lighter.
brighter, liver's
Brighter.
darker. Yeah.
Yeah. Sorry. Yeah. It should. So if it is brighter than the spleen, it's a it's
Big
likely.
problem. Yeah. And if it's isoechoic with the spleen, big problem as well.
Yeah.
Okay, normal gallbladder. If this was full of sludge, but it still looked like there was no wall changes, also normal gallbladder. In dogs, not in cats. Now I'm actually going to just jump out and jump ahead a little bit to show you some pathology of scans in this region. Ooh, and some artifacts. So the bladder kind of has snuck in. I'm all out of order. Okay, gallbladder. What are these?
Just dull enhancement.
These the
The shadow.
Reverberation artifact.
Yes. Or is it reverberation? I call it beam hardening artifact. So when ultrasound waves go around a curved edge, they can't bounce back and you get shadows around the curved edge. So if this wall was quite bright, it would be quite hard to say whether it was mineralized or not. So if you're seeing like dark lines on the edge of a round structure, just look at it from a different angle and just see whether you're thinking mineralized or not. Distal acoustic enhancement is actually a good one to talk about, Jeff. So what is the physics behind that, Barry?
Well, the beam travels better through the
Mhm.
through the anechoic structure, so it'd be brighter distal to it.
Exactly. So if we've got the probe sending out the same amount of ultrasound waves, and the ultrasound waves either side of the gallbladder have to go through really thick liver, and all the time, because it's like quite dense, it's reflecting all the sound waves back. So the sound waves that have gone through gallbladder and fluid, those sound waves have bounced through fluid that hasn't reflected anything back. So more sound waves have gotten to the tissue distal to that. So more sound waves have then bounced back from here than have bounced back from here. So the tissue here, and this is not a great example of this, is going to look brighter. This is a good example of this. So the tissue here looks brighter than that. So that's distal acoustic enhancement. So distal to the anechoic structure. Does that make sense?
Yep.
Yeah. Okay, cool. What about distal acoustic shadowing?
Where you've got something like a stone that's stopping
Great.
sound waves and sending them all back. There'll be
Yes.
a black line beyond it.
Yeah, exactly. So if you've got something that no sound waves can get through, that you're not going to get any ultrasound signal from underneath it. Okay, so this is a good example of what we might see from that window. So this is liver. You can see some liver lobes up here. If you've got a liver mass, it might be floating in free fluid, might not be. But if you just put your probe on there and you've fanned, and rocked and slid, you're going to have seen most of the liver. So we've got some free fluid here. What do you think about this free fluid? Is it
It's
likely to be ascites or heme abdomen?
ascites because there's not a lot of speckling with it, which you would be more likely to get if you've got blood cells or pus cells.
Yeah, exactly. So sometimes you can see a free fluid and you go, oh, it looks a little bit like tissue, and you know there's a lot of cells in it, if that's the case. So you can get a bit of an indication. And sometimes I like to say, let's just do coags before we stick needles in this dog, to find out what it is. It's particularly, obviously, if you've seen a mass, then it's unlikely to be a coagulopathy. But if you see an echogenic effusion and you don't know where it's come from, and you've done your POCUS, you haven't found a mass, you probably do coags before you stick needles in. Excellent. Okay, let's move on to going back to our windows. If we move down to number 2, which is our bladder window, which is, what are we going to see in our bladder window?
Do I get a point for saying the bladder?
Yeah.
A non-echogenic fluid-filled structure.
Yeah, pretty much. Yeah, you might see some stones. So if they've presented obstructed, you might sort of say, okay, well, this is very likely to not be a neoplastic obstruction because I can see there's other stones in the bladder. The bladder is the other place where there's that kind of meeting of round structures and free fluid accumulates. And I reckon this is my favorite spot to see very low volume effusions. This little triangle off the cranial pole of the bladder.
Now, I noticed that on the diagram, you're not looking midline at that. You're looking on the dog's right side.
It actually depends very much how the dog's positioned or animal's positioned. So if they're standing I'll definitely be midline. But if they're in right lateral recumbency, sometimes I look a little bit from the lateral aspect. It doesn't actually make a huge difference to the image that you're getting. The main hot tip I want to give for this particular view is if you put like in an emergency situation, you're kind of like, oh, I can't see very well, and you end up pushing quite hard. And what can happen, so this is a view of the bladder. This is how it interacts with the colon. If you push hard, that bright white shadowing structure ends up in your bladder, in your image. And I can't tell you how many times I've been called to do an ultrasound in a dog with bladder stones, only to find the colon next door to the bladder. It happens all the time, and it not like no judgment. It will definitely happen to you. You'll be like, is that a stone? Or no, actually it's the colon. And the key to that is making sure you've got really good contact so that you can back off on pressure a lot. So you're not displacing any of these structures. We want to see them in their native environment, not displaced and pushed up against each other. Make sense?
Yes.
Cool. So whether you're looking from laterally or ventral, like completely ventrally, it's completely fine. But yeah, same, the colon or guts, from whichever way you're looking, are going to get in the way. Okay, so the third spot is I'll go back up to our diagram, our right paralumbar and hepatorenal spot. So there's a bit of a giveaway in that name. What are we looking for in this spot?
Well, the right kidney,
Mm-hmm.
which is
Cool.
defined, it's well forward and it's tucked in up with the liver
It's really hard to find.
and the pancreas.
I actually find this, the right kidney, sometimes I'm like, oh, doesn't have one. No. And in fact, they have had a couple of cases that didn't have a right kidney with Matt's kidney. Um, but it's actually a really hard view to get. So you want to have a few different approaches to it according to what type of dog you're looking at. So as an example, if you're looking at a greyhound, there's no part of the kidney that's outside of the rib cage. It's all under the rib cage. And likewise, cavoodles are actually very athletic build, very narrow chests, and their little caudal ribs tuck right in. And when you stick your probe up under them, they really don't like it. So having an approach that lets you look both through the ribs and subcostal is nice to have up your sleeve. If you've got like a French bulldog or a square dog whose diaphragm's quite vertical, their abdomen's in their abdomen. It's easy to see everything. Whereas if you've got a dog that on x-rays you'd expect to have a lot of the abdomen up under the ribs, then I'd be prepared to do a little bit of intercostal dancing around for this one. But essentially, go more dorsal than you think you need to. They're very dorsal structures that we're looking at up here. So what I do in dogs is feel for the last rib and feel for where the soft abdomen meets those the hypaxial muscles. I'm feeling it on myself, which doesn't help you at all. Sorry. Do you know what I mean though? Like that soft spot that's like right in the nook of their ribs and the caudalmost aspect of their abdomen. So if I look at this dog, it's going to be right up there, like the most dorsal soft part I can get in the abdomen. And then I'm going to point my probe 45 degrees cranial and 45 degrees dorsal. So like in under the ribs. And usually you'll find your kidney there. And the nice thing, if you can get the view, is you can actually look at the liver and the kidney next door to each other in this beautiful picture. And that allows you another opportunity to check on the liver's echogenicity. It should be the same or slightly brighter than the renal cortex. This is a bad example because the kidney's brighter than the liver. And the trouble with this is that most older dogs have a little bit of fibrosis in their kidneys. So we often have slightly bright renal cortices. What else can you assess in the kidneys? What would you like to be able to detect in the kidneys?
Pelvic dilation.
Very nice. Here is a little review of pelvic anatomy. Can you see that all right?
Mm-hmm.
So if we're looking at the kidney in cross section, is our probe going to be pointing towards the head or the spine, our notch?
Towards the spine.
Yay, excellent. So if you're pointing craniocaudal, we know that kidneys sit craniocaudal. So if you're pointing to the head, you're going to get a longitudinal section of the kidney, a long axis. And you do get an impression of renal pelvic dilation in that view, but the standard view for measuring renal pelvis is in short axis. So you want to turn your probe 90 degrees. So we're going to rotate is the term I should be using, not turn. And if we look at what the renal anatomy looks like, you shouldn't see a normal ureter. You should never really see it. But you will see blood vessels, renal artery and renal vein coming in the renal hilus. So if you see those, you know you're in the right spot. So we're going to have some cortex. We're going to have some medulla. In a normal kidney, is the cortex darker than the medulla or lighter?
The cortex.
Brighter.
Brighter. Good. Yeah. So the cortex is quite bright. The medulla is nearly black. So if we see this kidney is obviously not a normal kidney, but the cortex here, that's a relatively normal looking cortex. And then that's a relatively normal looking medulla. And then here we've just got this little called the crest. And that kind of outlines our renal pelvis. In a normal patient, you can see here, the renal pelvis is not visible. You might be able to see these tiny bright white lines there. So it's sort of outlined here in red. These bright white lines are a calyce coming off the side of it, and the renal pelvis will just look exactly like that. It's a potential space that shouldn't have anything in it. So when we get some dilation, this is the pattern that we get. Can everyone see that?
Yes.
Can you see how bright the fat is at the renal hilus in this patient relative to this one?
Mm-hmm.
So we've got not just renal pelvic dilation, but we've got evidence of some pathology here, some inflammation abnormalities. So this is a 6.5 millimeter renal pelvis. It's pretty big. We don't see them that big very often. This is a much, much bigger one. And once they get bigger than about a centimeter, you lose this anatomy completely. They've just kind of like started to lose that renal tissue due to pressure necrosis. And you start to get kidneys that just look like capsules of kidneys over time. If you've got a kidney that looks like this, it's not an acute problem. It's been around for a while, at least a couple of weeks. Well, at least a week, I should say. They take a while to get that big.
The normal dog's on fluids, Anna.
Mm-hmm.
Would you get dilation of that?
Not dilation. We accept up to 3 millimeters as normal for dogs that are polyuric. So presuming they're on fluids or producing more urine for another reason. So often Cushingoid dogs, often dogs with renal failure will have slightly dilated renal pelvises, but they still sit within the normal range. So we're given a bit of buffer in our normals to account for that.
3
It'll
millimeters.
be over 3 mil. And you should never really be able to see the ureter. If you can see the ureter, there's a big problem. Like there's either an obstruction or a really inflamed ureter. Okay, so that's our right paralumbar hepatorenal view.
Do you also look for fluid in the like subperitoneal space, retroperitoneal space?
Great, excellent. Yeah, absolutely. So they're different spaces, aren't they? So peritoneal, retroperitoneal. And what sort of pathology would result in retroperitoneal free fluid, but not peritoneal free fluid?
Rupture of an artery.
Good.
Large.
Yeah. Yeah. Like so traumatic incidents. It's a pretty well protected area. So often we'll have peritoneal free fluid if they've had an injury to the vessels. What else?
Renal neoplasia.
Yeah, good. Excellent. So like a bleed from like a renal hemangiosarc or something like that. The other organ in that space that bleeds sometimes is adrenal glands. Adrenal tumors can rupture and cause like a really significant retroperitoneal hemoretroperitoneum. And it's really hard to work out where the blood's coming from.
I think you can also get urine in there too, Anna, can you?
Right. Excellent. Yeah. What injury would have occurred if you had urine in the retroperitoneal space?
Oh, a ruptured ureter.
Perfect.
Ureter, yes.
Yep, exactly. And then the other time we see it, much smaller volumes, but actually pyelonephritis. So if there's really significant inflammation of the kidneys, you can get little slips of free fluid around the kidneys, not uncommonly. Ureteral and bladder urethral obstructions, we sometimes see retroperitoneal fluid due to the backup of pressure into the upper urinary tract. So that right side, Matt mentioned earlier, where would we screen for pancreatitis? If you're looking particularly intercostally, I don't have a picture of it, I don't think, but you've got like kidney sitting here, and then there's duodenum right here. And who sits right next to the cranial duodenum?
Pancreas.
Pancreas, exactly. So if you've got a really nice picture of your kidney and you just go slightly ventrally and there's a gut in a straight line, there's not many guts that run in straight lines, it's probably going to be duodenum. And if you don't have a like localized area of inflammation in that area, you probably don't have pancreatitis. If you do have inflammation in that area, then pancreatitis would be the most common cause of that. But then it's also an area that we do see ulceration commonly. So if you, for example, they had a history of starting non-steroidals last week or something like that, and you saw some inflammation there, I would just be a little bit suspicious. It's a really nice view of the duodenum through there. Okay, what about site number 4, which is our left paralumbar splenorenal? What are we going to look at?
Spleen.
Spleen, yeah. And our left kidney, obviously. What are we looking for in our spleen?
Masses.
Mhm. Yeah. So we can have dogs get quite significantly anemic or clinical by an intratumoral bleed. So sometimes there won't be free fluid, but you'll see a mass which looks very heterogeneous, so bright white areas, anechoic, cystic areas, and that can indicate a recent bleed. What will the area around the mass look like, even if there's not free fluid? Would you expect it to just look normal?
Well, probably.
Most of the time we get this like little bit of bright fat that sticks to the outside of the mass. So it just is a little bit reactive. And sometimes that's a bit of a signpost. So sometimes I'll put the probe on and I'll be looking at the kidneys or something and I'll be going, oh, like there's something, that fat's telling me I need to focus there. So keep your eyes peeled for not just mass lesions, but also little hallmarks that there might be focuses of inflammation. And when fat gets annoyed, it gets really bright and it puts up a flag saying, look at me.
That's something.
Spleen, it's tricky to assess, and this is another situation I'd encourage you to explore intercostal viewing. Because the head of the spleen, if you think about your surgical anatomy, if any of you are surgeons, the spleen is like so far up under the ribs, the head of the spleen, and it's really easy to miss a mass in the spleen because you've checked the whole spleen that's in their kind of abdomen, but not looked at the head of the spleen. And if you can see the left kidney intercostally, your spleen is going to be sitting immediately cranial to that. And then the other nice thing, if you're kind of seeing big spleen in the abdomen and it's kind of everywhere, if the head of the spleen is not immediately cranial to the liver, to the left kidney, sorry, it might be torsed, might be displaced. So it's a nice view to get used to seeing kidney and spleen next door to each other. Let's see if I put that in here.
Can you see evidence with torsion within the parenchyma of the spleen without sort of having a clue of displacement? It depends where they are in the.
Depends how long it's been torsed for. So it's got a really distinctive pattern when it's been like that for a week. but in the first kind of 2 days or so, it can look bright and big, but not necessarily have parenchymal changes. So the way that they describe the parenchyma is lacy when it has developed those changes. And once you hear that word, like if you see it, you recognize it. Like it's so distinctive and there's nothing else that it could be. But we see splenic torsions before that happens, so you can't rule it out by the absence of that.
Do you see many? Or
Nah, like 3 times in my life.
yeah.
I wonder how many I've missed.
And are they are the dogs stressed, like behaving like a GDV, like or
No, it's
just
much more
not
subtle. So there
not
might
quite
be like just off their food a little bit, like sometimes vomiting, sometimes like really sore and flat, but like not really localizable. I reckon it's really tricky to diagnose.
It could look like a mild pancreatitis or
Quite easily. Yeah,
gastro.
clinically, for sure. Yeah. And often they're not quite sick enough to warrant like, extensive investigations and stuff. And often they're big dogs as well. So it's quite hard to get really high resolution images of the splenic parenchyma and stuff. And also because you've got to push so hard, you distort the anatomy, it's actually really hard to see what's in its normal place on ultrasound. CT is much better at.
And can they spontaneously replace
Mhm.
themselves?
Yeah.
Yeah, so you would never know if that was just like that the dog spontaneously healed and
Mhm.
that's what had happened.
Exactly. Yeah.
Okay.
Yeah, I reckon it's one of the trickiest diagnoses just because I think it probably happens partially, like in a lot of dogs, like coming and going, and they're like, oh, a little bit painful, a little bit uncomfortable, a little bit off their food. Oh, they're better. Oh, like, so I'd be, yeah, interested in a better way of diagnosing that. Like, there's got to be some biomarker or something like that. But
Well, maybe lactate goes really high, like, but
they're still getting arterial flow though,
yeah.
and the lactate's stuck in the spleen. It's not because it's often they've not got the venous outflow. So I'm not sure that systemic lactate would actually go up, would it?
Not sure.
No. Yeah, if anyone sees a study on that, tell me. Okay. Last site is just in the middle. Like put the probe straight on the umbilicus and have a look around. Do some sweeping, some rocking, some fanning, all of your kind of movements and rotating. And just make sure you're not missing something like a kebab stick sitting in the middle of the abdomen. It's happened. And obviously there's a lot of like, if you, particularly in an emergency situation, you often haven't clipped that well. And you sometimes I sort of say you should slide, but the spleen might be going from like, might be taking up the whole abdomen. You probably haven't assessed the whole thing from your left splenorenal window. So that umbilical view allows you to just assess for the liver hepatomegaly as well, if the liver is extending down to the level of the umbilicus. Splenomegaly if it looks huge, more free fluid. So the other thing I want to just highlight is if you're doing that view and you're not seeing any free fluid, why might that, but you're pretty sure there is free fluid, why might that be? Where would free fluid go depending on position of the dog?
Going to
Eventually.
fall gravity dependent. So if you've got your dog in lateral, you might, if you're checking for free abdominal fluid, you might need to just fan your probe down towards the table. And if you're looking for free abdominal air, like if you suspect a septic peritonitis or something from bowel rupture, you'd want to fan towards the ceiling with the dog in lateral so that you can look for air rising and fluid falling.
Perfect. Yeah, exactly. So if you're free fluid, I actually really like assessing dogs' umbilical view with them standing. So when they first come in, I'll just be like, well, there it is. Because it's gonna, all of the gas-filled intestines and stuff are gonna float on top of it. If I'm looking for gas, like Helen said, I think gas is like one of the hardest things to find. What does gas look like on ultrasound?
Black. Black.
Yeah, so just a big shadow. What happens to sound waves when they hit gas?
They stop.
Yeah, they just diffuse. They're just like, It's sort of similar to, going back to the whales underwater. Whale song travels for kilometers underwater. If that whale made that same noise on land, no one would hear it. It's the air just
That's
distributes
like how
sound.
giraffes talk. They've just figured out.
What do you mean?
They just discovered that giraffes, which science thought was silent, have low grumbles that they've now picked up that are like whales,
Really?
and they hear that only they hear it.
So too low frequency for us to hear?
Yeah.
Wow. That's cool. Um, Yeah, so air just like, so you're sending your ultrasound waves into air and it just scatters your waves and you just get a big ugly shadow and you can't see what you're looking at. So your instinct when you see air, when you're doing an ultrasound, is to look around it. Like you actually avoid it. And I watch people do this, like whenever there's free gas in there. We actually had an emphysematous cystitis the other day. Um, and yeah, and oh, Helen and I actually had a good one. It was a dog with a gallbladder abscess, and it had ruptured. It had a septic bile peritonitis and free gas in the abdomen. And Helen was like, "Why are there A lines? Why are there A lines?" And we were working on the contact, and we were clipping the dog closer, and blah blah blah. And it was gas in the abdomen. But your mind is like, why is this like an ugly image? So it is actually really hard to see. But if you then go, actually, I'm high side of the dog and I can't get rid of this. And when I move low side, my image is quite nice. And when I move high side again, it's ugly. Just like make a red flag go off in your brain.
Could you turn the dog onto the other side and repeat the process and see if
Abs
it happens again?
Absolutely. And sometimes it takes a while for the gas to bubble to the top. And this
Mm.
is this dog with an emphysematous cystitis. So Clostridial organism in the bladder. Causing with or any gas producing organism in the bladder. You sort of look at the bladder from laterally and it's sort of the bubbles on top. And so you just go like this and you get a beautiful view of the bladder. It would actually be really easy to miss it.
Mm.
And it wasn't until we kind of moved the probe and saw the gas kind of curving inside the like wall of the bladder and then a really nice image next to it that we were like, whoa. So yeah, I think just watch your tendency to avoid gas because you're always like, oh, it's the colon, or just check what it's in. All right, I think we probably need to wrap up. That was really fun and exciting for me.
Can I ask one really quick question?
Yeah, of course.
Could I ask, when you're talking about pyelonephritis with
Hmm.
fluid around the kidneys, is
Hmm.
it something like a lymphoma in a cat, but you've seen it in a dog and it's just subcapsular?
It's not subcut. It's subcapsular, do
It's
you mean?
yep.
Oh,
So
no, it can be, but often, like if you've got the round edge of the kidney like this, there'll be a little triangle of free fluid against the round edge. And often the fat's quite bright. So it's actually a local retroperitonitis.
and
Uh,
if you do see a dog with like a subcapsular fluid
edema.
buildup,
Yeah.
yeah, is it what you're suspecting, eh?
Mm, early but complete ureteral obstruction, pyelonephritis, or diffuse neoplasia. And the ways that I differentiate those is probably renal size. Like if we had, and the only real diffuse neoplasia they get is lympho in the kidneys because everything else causes masses. And in fact, lympho usually causes masses indoors as well, like focal nodules. Um, but yeah, something very infiltrative. And then I'd sort of, if the kidney looked big, then I'd say it's probably something infiltrative. But pretty much if I'm seeing that, I'm doing aspirates of the kidney or recommending aspirates of the kidney, as well as urinalysis and blah, blah, blah. And then there's other markers like, have I got like very focal inflammation at the renal hilus, which might suggest the pyelonephritis? Have I got very heterogeneous cortical echogenicity, which is something we see with pyelonephritis as well? Is there ureteral dilation? Is the ureteral dilation proximal only, or is it all the way to the bladder and the bladder is like really inflamed looking as well? So there's other things that would make me go, oh, it's more likely to be this.
Right.
But that finding in isolation, they're probably my three differentials.
All right, thank you so much.
Cool.
And
All right.
will you be doing emergency ultrasound of the chest, like A lines and B lines and so?
Yeah, I had the stuff to go through that today, and then I got too excited about the abdomen. So we can we can definitely cover that. I can't remember what we're doing next time actually. Um, Mm. Oh, we can cover that. Synthesis and biopsy techniques we're doing next time. So we're probably going to have enough time. Oh, yeah, how not to annoy your pathologist is the theme of the next one. So let's do like thoracic and cardiac focus for half an hour, and then synthesis and biopsy techniques. Good. All right.
So much, Hannah.
Thank
Thanks,
you.
guys.
Thank
See ya.
you.
Everyone. Bye.
Bye. Have a good day.